Hello and welcome to our online training. My name is Marcia Gelt and I am a project director for CARDIA. On behalf of the California Primary Care Association and CARDIA, we are pleased that you have selected this module to support your professional development. CARDIA is a nonprofit, mission-driven organization with a principal team of committed and passionate staff who have dedicated our careers to helping health and human service providers offer their best to their patients. You may be aware that CPCA is offering this training as part of their patient-centered Health Home Recognition Program. This initiative is for its member clinics to support their efforts to achieve Level 3 standards of National Committee for Quality Assurance Recognition. Erica Monasterio, who is a clinical professor in the Division of Adolescent and Young Adult Medicine at the University of California, San Francisco, will be the speaker for this module. By the end of this module, participants will be able to explain general adolescent brain development and describe at least 2 strategies for age-appropriate communication with adolescents. I'd now like to turn the presentation over to Erica.
Hello and welcome. In framing adolescent development, we usually think about it in terms of stages of adolescent development: early, middle, and late adolescence. As you can see from the slide, girls enter into adolescence at a younger age, and it takes until late adolescence or young adulthood for the boys to catch up. Commonly, people think about the enormous physical changes that go on in young people's bodies when they think about adolescent development. But there's actually a very broad job description for adolescents, and there are many tasks that they need to accomplish. Not only do they need to adjust to the changes in their bodies and the feelings that accompany their sexual maturation, but they also need to develop and apply abstract thinking skills. And with those thinking skills, they then need to be able to apply them to increasingly complex levels of perspective taking, something they don't generally accomplish until late adolescence or young adulthood. They also need to develop new coping skills because they are more and more responsible for making their own decisions, solving their own problems, and resolving the conflicts that arise with families, with family, with peers, and in their romantic relationships. And they need to be able to identify what are the moral standards, values, and belief systems that are meaningful to them in guiding their problem solving and decision making. As adolescents experience more complex relationships, they need to understand and develop the ability to express their more complex emotions. They form friendships that are mutually close and supportive, and these become the models for their romantic relationships. They're involved in pre-identity work, establishing key aspects of their identity, such as sexual, gender, and cultural identity. The demands on them change as well, and they're expected to meet the demands of increasingly mature roles and responsibilities as they get older. And finally, they need to renegotiate the relationships with adults in parenting roles in their lives. This is a job that may start in adolescence, but often isn't completed until people are in their 40s or even their 50s, as there's a transition with their relationships with their parents. It's also one of the most challenging aspects of adolescence for parents to accommodate, because this involves not only youth renegotiating their roles, but the parents as well. So let's start by looking at early adolescence. As you can see in this picture, the girls in the front look like budding teens, and the boys in the back look like little guys. And it is a great picture to think about why it is that there's generally a 2 to 3 year age difference between boys and girls in their romantic relationships, because those little guys in the back might make good best friends, but they're not necessarily objects of romantic desire. The overwhelming question for early adolescents is, am I normal? They have a lot of adjustment to make as their bodies change. They're increasingly concerned with body image and privacy, and will go from parading around naked to barring the door to the bathroom from one day to the next. They begin separation from their families and have increased parent-child conflict. However, this tends to be mild bickering that parents take far more seriously than the youth do. Parents will be very concerned after a confrontation with their child, spend the evening discussing what went wrong, and want to talk about it in the morning. And when they bring it up over the orange juice, their child is likely to say, no big deal, I got to go to school. They also tend to be very self-preoccupied, very egocentric, and very involved in their fantasy lives. Early adolescents are extremely moody, and a labile mood is a characteristic. This is not to say that you can't find serious mental health issues such as bipolar disorder in early adolescence, but the range of normal is so broad that many mental health professionals are reluctant to make these diagnoses in early adolescence. Young teens tend to form friendships with same-sex friends and to be engaged in group activities, and supervised group activities are a good outlet for early adolescents. They're concentrating on their relationships with peers, but they're still very attached to parents and family. And although they are concrete thinkers, they're beginning to explore their new ability to abstract. They do tend to be very focused on the here and now. One of the most fascinating aspects of early adolescence is cognitive development. Early adolescence is a highly active period of brain development, and we are now developing a biological explanation for the transition in thinking from concrete to abstract. We used to think that most brain development was completed in the prenatal period, and that certainly by age 3 to 5, brains were pretty much finished. But as you can see in this graph, there are certain areas of brain development, such as synaptic refinement, shown in the dark purple line, or myelination, shown in the violet line, that are highly active during the period of adolescence, particularly early adolescence. But as you can note with myelination, this is a process that isn't complete until around the age of 30. These images show brain development from the age of 5 to 20. The areas that are hotter, yellows, reds, are areas of more rapid or intensive development, and the areas that are cooler, the purples and blues, are areas where development is more complete. As you can see, development moves from the back to the front of the brain, and there are areas such as the red cleft there at age 20, which is the growth of the corpus callosum, that is still undergoing change even into young adulthood. Now here's a little reminder of brain anatomy, because we are going to be talking about these different areas. Areas that you particularly see change in development in adolescence include the cerebellum, there in the back of the brain, the amygdala, and the corpus callosum in the middle, as well as the hippocampus, and the prefrontal and frontal lobes, which aren't labeled here but are in the front part of the brain. These images focus on brain development just during the adolescent period. So the top brain is the brain at age 12, the bottom is the brain at age 20. And again, note that there are areas that are still in those hot colors of yellow and red where there's a lot of brain development going on. One of the key areas we focus on in terms of brain development in adolescence is the prefrontal lobe. This is the CEO of the brain, the seat of reasoning ability, goal setting, and priorities. Some of the interesting things about the prefrontal lobe are not only that it is less developed in adolescence, but it also responds differently. For example, stimulus that triggers prefrontal lobe activity in adults will trigger the amygdala, one of the more basic parts of the brain, in early adolescence. And as the prefrontal lobe matures, impulsivity decreases. These are images from fMRI, or functional MRI, of the brain of an adolescent and adult. This is from a study that was done showing adults and adolescents standardized facial expressions. Now, most of you listening are probably adults, and probably that picture signals to you someone who is experiencing fear or shock. And the part of your brain that has processed that image is in the frontal lobe, which you can see on your right. The adolescent, however, misinterprets this facial expression as anger. And the part of their brain that responds is in the limbic system, the amygdala. So you can see that the brain function may be the seat of many of the misunderstandings that go on in communication between adolescents and adults. They see that face and they think they're angry at me, and the part of their brain that sees that image and interprets it as anger tells them either get out of here or fight, versus the adult who sees shock or fear and processes it in the seat of their reasoning ability. In terms of frontal lobe development, where planning and decision making and impulse control are found, this is the last part of the brain to myelinate, and it is the part of the brain that experiences the most pruning, or a decrease in the number of synapses or connections. The theory is that perhaps you either use it or lose it. A good example of this is the ability to acquire a new language. Although language can be acquired at any age, it's much easier to acquire language before the age of 12 or 14. And language that is acquired before the age of 12 or 14 is usually spoken without a notable accent. This is because the connections in the brain for a language acquisition are present still in the early adolescent brain, but as we move towards adulthood, those connections die off because language acquisition is generally completed and we don't need them anymore. Here in the picture on the left, you see this illustrated. This is synaptic pruning, and you can see that the connection that isn't being used is going to die off. You can see that red X. Now, the other thing that's going on is myelination. This is like the rubber on the wire, the coating that allows nerve impulses to be more efficiently conducted and more quickly conducted. So the connections that remain are thicker, stronger, and more efficient, and the connections that aren't being used die back. As you can see from this graph, actually the peak of frontal gray matter is around age 13, and after that the adult brain has less gray matter. This doesn't mean that we think less clearly, it just means we think more efficiently, and the neuronal pathways are more refined. This is a picture of neurons, and I included this picture so that you could actually identify and remember that these are the connections that we're talking about. These are the connections that become myelinated, as well as the connections that are pruned. So we've spent some time talking about the frontal lobe, but that is not the only part of the brain that is changing, growing, and being refined during adolescence. Adolescence is also when there's the peak growth rate of the corpus callosum, the connection between the two hemispheres of the brain. This results in faster signal transmission in the networks that support abstract and associative thinking. And it's believed that creativity and, quote, intelligence are linked to that integration between the two hemispheres of the brain. The work that's been done looking at the role of the corpus callosum has been based on adults who've had traumatic brain injuries that have actually severed the corpus callosum. And they have found that in situations where that connection between the two hemispheres is lost, the ability to abstract is also lost. The characteristics of concrete thinking are the characteristics of early adolescent thinking. It is a present orientation where seeing is believing and my own experience or my friend's experience is what counts. So, for example, don't bother telling me about what happens to girls statistically who have babies when they're 15 because my best friend had a baby and she's doing much better than she used to do and she's now a peer educator and her baby's so cute, and you're not going to convince me that this is a problem. Their ability to project into the future is relatively limited, and when they do project into the future, they're not very realistic about it. They're not so different from 5-year-olds who want to be firefighters or police because they like to drive red trucks or fast cars. They're often not motivated by their interests or their abilities in choosing their futures. And most importantly, they literally do not have the brain function to perceive the long-range implications of their current decisions. So when you ask an early adolescent, didn't you realize that if you spent all night talking to your best friend on the phone about the fight she had with her mother, you were going to flunk geometry, and if you flunk geometry, you can't take algebra, and if you don't take algebra, you'll never get to calculus, and how are you going to be able to go to university? No, they didn't think that. They thought, my best friend had a big fight with her mother, and it's the end of her world. Now, these are the characteristics of abstract thinking, and the abstract thinker is every health professional's dream. They can envision alternatives, evaluate them, engage in perspective taking, reason about chance and probability, and most importantly, prioritize. So when we think about adherence to medical advice, it involves being able to engage in all these activities that early adolescent brains are not capable of doing yet. Now, this isn't to say that there aren't abstract thinkers who are early adolescents. Each young person's development is unique. However, in general, they are much more concrete than abstract. So let's talk about adherence and the ability to follow directions and even understand directions. Here's a handout that was developed for teens about what to do if they missed their birth control pill. As you can see, there are a lot of words, a lot of if this, then that on this instruction sheet. Here's an example of a more adolescent appropriate missed pill instruction sheet. As you can see, there's lots of graphics, not so many words, and pictures of exactly what to do when. In terms of sexual development, early adolescence is a time of self-exploration, and masturbation is quite common for both boys and girls. There may be sexual experimentation with same-sex peers, and this has no determination on their future sexual orientation. Sometimes well-meaning providers will say to a parent, oh, don't worry, just because you caught Julie French kissing her best friend Joan, that doesn't mean she's a lesbian. Well, it doesn't mean she is, but it also doesn't mean she isn't. And so the most important message to give parents here is that it really has no impact on determining their future sexual orientation. In early adolescence, sexual intercourse is pretty uncommon. As you can see from the data here, a small percentage of girls as well as boys have sexual intercourse under the age of 13. Of key note, however, is that between 8th grade and 9th grade, this increases dramatically, so that with 3.1% of girls and 8.4% of boys at under 13, we have an increase to 31.6% of 9th graders reporting having had volitional sexual intercourse. Also of note is that for those who are sexually active, about 18% report that they have experienced unwanted sex, and over half report mixed feelings about having sex when they were less than or equal to 14 years old. So how does a provider relate to an early adolescent? Well, you want to use communication tools that are very specific. More pictures than words is good. Demonstrations work better than explanations. Anything that supports the information in written or visual terms is helpful. Focusing on the issues that concern early adolescents the most, their physical appearance, their acne, their relationship with their peers, gives you the opportunity to respond to their concerns and then perhaps express some of yours. And remember that early and late physical maturation can lead to difficulties with peers and relationships. Particularly, we know that early developing girls are much more likely to be involved with older partners, engage in sexual intercourse at an earlier age, and deal with all of the unwanted experiences that accompany early sexual intercourse, such as sexually transmitted infections and unplanned pregnancies. Most importantly, when working with early adolescents, while respecting their rights to minor consent and confidentiality, it's essential that providers engage with parents when they can. Encourage parents to maintain their parental role and monitor, set limits, and communicate with their kids. Make sure that parents are encouraged to maintain their connectedness. Let their early adolescents know that they love them and care about them and are there for them. Because parents who engage in these activities have children with reduced sexual risk. So let's move on to middle adolescence. And when most people close their eyes and think about teens, this is what they see: the high school kids hanging by their lockers. Middle adolescents have become less concerned about whether they're normal and very concerned about whether they're attractive, although their ideas of what's attractive may not be the same as yours or mine. They are increasingly independent from their family, and their peer group has become the predominant affiliation. They gauge what is appropriate behavior by what they think everyone else is doing. Experimentation with relationships and sexual behaviors is normative in middle adolescence. Although not yet solidified, there is increasing movement towards forming sexual orientation and sexual identity. And there's an increased abstract thinking ability. However, they are still not mature and often have difficulty applying what they know to what they do. Often you will find a middle adolescent who can tell you everything about appropriate and proper condom use, but when it comes to the heat of the moment, does not make the choice to use a condom. They are developing their ideals and selecting their role models, and this is an age when mental health issues become quite significant, particularly depression. In terms of sexual development, dating is common, and sexual experimentation with outer course and oral sex is also quite common, with more than half of young men as well as young women engaging in sexual experimentation. So this is everything other than sexual intercourse. However, sexual intercourse is also quite common, with 53% of 11th graders and 62% of 12th graders reporting having had intercourse. So what is it about middle adolescence and brain development that makes risk-taking such a predominant aspect? Well, remember that the brain develops from the back to the front. And so that earlier development of the back of the brain leads to preference for physical activity, less than optimal planning and judgment, more impulsive behaviors, and little thought or consideration for the negative consequences of their behaviors. There are many aspects, anatomical, physiologic, and social, that impact on middle adolescent risk-taking. The nucleus accumbens, which is in the part of the limbic system, is highly sensitized in adolescence. There are hormonal influences because during puberty, increased testosterone and estrogen bind to the limbic system receptors. There's a decrease in dopamine, but there's an increase in dopamine receptors, so there's less to go around. And peer and societal influences are quite predominant in influencing risk-taking behavior. Recently, theorists and brain scientists have been trying to make sense of why it is that adolescent risk-taking is so predominant. If it were just related to prefrontal lobe development, then we should see that children are more impulsive and more involved in risk-taking than adolescents because their prefrontal lobe is even less developed. The current theory is that it is the balance between reasoning ability and emotional dysregulation that results in risk-taking. With amygdala activity more predominant and the activation of the nucleus accumbens in the limbic system, these influences outweigh the development of the prefrontal lobe. This diagram very clearly shows how the limbic regions, which are developing faster than the prefrontal regions, really overwhelm the reasoning ability of the prefrontal region, resulting in increased risk-taking. Not only are there structural differences, but there are differences in the neurotransmitter activity in the adolescent brain. As I mentioned before, there's less dopamine being produced, and this results in mood changes and difficulty with emotional control. There's also less serotonin produced during adolescence, and this results in a decrease in impulse control. And finally, the rate of production shifts in adolescence for melatonin, which results in increased sleep needs, at the same time that adolescents are generally sleeping less than children or adults. So let's focus on these specific neurotransmitters. Dopamine increases the capacity to learn in response to a reward and is critical for focusing attention to choose between conflicting options. Dopamine inputs in the prefrontal cortex grow dramatically in adolescence, but as mentioned before, the amount of dopamine is actually less. Other areas of the brain that are developing in adolescence include the cerebellum, the seat of physical coordination, and theoretically, possibly social interactions and problem solving. The amygdala, the home of emotional memory, or how you feel about something, and where we process and experience fear, danger, and threat. And the hippocampus, where actual memory, factual memory, and the capacity to absorb and store information is seated. This is an area of development that educators are very aware is growing and developing in middle and late adolescence, and we see that in the context of the amount of information that high school and early college students are expected to process. We've talked a lot about risk-taking in middle adolescence, and substance use is certainly one manifestation of risk-taking. It's a manifestation of risk-taking that actually has an impact on brain development, and concern about adolescent substance abuse or involvement is most significant as it relates to its impact on brain development. So in looking at areas of the brain that are impacted by substance use, most important is the synaptic cleft. This is the site of action of many substances of abuse. Particularly stimulants such as cocaine and methamphetamines lead to an increase in dopamine at the synaptic cleft during use and a chronic depletion after use. The hippocampus, another area we have discussed in terms of brain development, where memories are formed, is significantly impacted by alcohol and marijuana. Alcohol disrupts neuroplasticity in this region, and heavy use can actually cause permanent changes. Studies done with college students have shown that heavy alcohol use, even in late adolescence, leads to atrophy in areas of the brain. This is an illustration of the area we were talking about, the synaptic cleft. And you can see that dopamine is being released to the dopamine receptors. And so in the picture of stimulant abuse, these areas would be flooded with dopamine during use and then depleted after use. This is an image of the adolescent brain exposed to significant alcohol use, and you can see that the hippocampus is actually smaller and atrophied in the brain of an alcohol-involved adolescent. This is the reason that alcohol has a significant effect on memory, and this effect on memory is long-lasting. The blue line here shows an alcohol-dependent brain's ability to assimilate verbal on the left and nonverbal on the right information as compared to the non-alcohol dependent brain. And this is a common problem among adolescents. As you can see from the data from the Youth Risk Behavior Survey, high school students in 2009 almost half reported current alcohol use, with a quarter reporting binge drinking. A fifth reported current marijuana use. Close to a fifth reported current cigarette use, and other illicit drug use really varied. The big three here are alcohol, tobacco, and marijuana. Not only are there physiologic and structural brain impacts to substance involvement, but there are many problems associated with adolescent substance use. We see unintentional injuries, including deaths, knowing that most motor vehicle accidents with adolescents are under the influence of usually alcohol. There's an increase in suicidality. Because of problems with impulse control, we see increased aggression as well as victimization. There are infections and pregnancies related to coerced, unplanned, and/or unprotected sex under the influence. Youth who are involved in alcohol and other substance use tend to have academic problems and social difficulties, and family conflict and dysfunction becomes a predominant issue. Adolescent alcohol abuse has a significant impact on lifetime substance involvement. Almost half of those who start drinking before the age of 13 developed a substance abuse problem, compared to only 9% who started drinking after their 21st birthday. 1 in 3 children start drinking by the end of 8th grade, and half report having been drunk. And alcohol dependence is more common among older adolescents than among any adult age group. Alcohol use is the most common substance of abuse in adolescence, with young men being slightly more likely to be alcohol involved than young women. But as you can see, current alcohol use, close to 30% of young men and 24% of young women have used alcohol within the last month. And of greater concern is almost a fifth of young men and 14% of young women report binge drinking within the last month, and 6.7 versus 3.5% of boys and girls report heavy drinking. Because of brain vulnerability, peer norms, and social expectations, we can look at addiction as really a developmental disease starting in adolescence. With tobacco shown in pink, marijuana in orange, and alcohol in blue, you can see that the peak of first-time dependence for all of these drugs is in late adolescence and young adulthood. Traditional approaches to intervening with adolescent substance abuse have been universal prevention strategies, primary prevention aimed at those who have not yet initiated use, and then on the other extreme, specialist treatment aimed at those who are dependent. Much less work has focused on that large group of young people who are not or not yet dependent and who could successfully reduce their usage through an early and brief intervention. SBIRT is a model that's been developed originally for work with adults, but is highly applicable to working with adolescents who are beginning substance involvement. The S stands for screening, the BI for brief intervention, and the RT for referral to treatment. The goals of SBIRT are to use adolescent-appropriate screening tools that identify the full spectrum of risky substance abuse, from problematic use to abuse to dependence, and to build the skills and to understand how to use brief advice and brief interventions for adolescent substance use. The evidence is primarily with adults, where brief interventions with follow-up provided to adult problem drinkers in primary care have been found to reduce alcohol consumption. The U.S. Preventative Services Task Force found that there was good evidence that brief interventions with follow-up yielded small to moderate reductions in alcohol consumptions, and these reductions were sustained over 6 to 12 months. There's less evidence with adolescents, but research has shown that brief interventions are effective in reducing risk, drinking rates, and harmful behaviors in college-age youth. There is no evidence for current practice in younger adolescents. Brief interventions with adolescents should not only be appropriate to their developmental stage, but also to their stage of use. For example, an early adolescent who responds to your questions around substance use with, "Oh, I sometimes have a drink on New Year's with my parents, but I don't like how it tastes," or I wouldn't use marijuana, that's illegal. You want to give them positive reinforcements for their healthy behaviors. For the adolescent who has begun experimenting or is even involved in some regular substance use, you want to engage in risk reduction, helping them to find less harmful drugs and less harmful ways of ingesting their drugs, as well as reducing their risk related to motor vehicle, diving, or swimming accidents. For the adolescent who manifests problem use or abuse, you want to engage in motivational interviewing and a brief intervention oriented towards reducing use. And for those who are drug dependent, you want to not only engage in motivational interviewing, but they need a referral to a treatment specialist. And the focus of the motivational interviewing may be just moving them towards acceptance of treatment. Motivational interviewing is a skill set that can be utilized by providers in looking at any aspect of behavior change. The stages that one might want to use with examples for substance use is first to develop discrepancy between the youth's substance use and their ability to fulfill their own goals. For example, the young person who tells you, I want to finish high school and go to college and become a doctor, and they're smoking marijuana daily, it might be useful to point out to them the impact that marijuana has on their ability to retain and process information. You want to always avoid arguing. You don't want to get into an oppositional relationship with the young person who you're trying to counsel. And to re-roll with their resistance. Actually expect their resistance and meet their resistance with empathy and reflection. Support their sense of self-efficacy by not telling them what to do, but rather asking them, what would you like to do about it? And express empathy and acceptance by listening rather than telling and working with their ambivalence. Because for any health-damaging behavior, there are reasons that people engage in it that make sense to them, just as there are reasons that they know they should alter the behavior. Substance abuse and adolescent experts advocate using a tool in primary care for assessing the level of substance involvement in adolescents, rather than trying to gauge it solely on the basis of what you obtain in a history. The CRAFT, which has been validated with adolescents as an appropriate screening tool, can be self-administered or done in interview form and is available in both English and Spanish at the website cited on the slide. So, in working with middle adolescents, it's important to develop a friendly relationship because you want to create trust. Now, this doesn't mean that you become their best friend or that you dress like them or talk like them or look like them. And in fact, if you tried to do that, they probably wouldn't feel very trusting of you because you're clearly an adult and a professional. But less formality, more willingness to be accessible and engage in conversation is helpful with middle adolescents. Healthcare messages and tools that the teen can identify with will assure follow-through and success. Make sure that your written materials are in a language and at a level that they can relate to. Make sure there are more graphics, pictures, and bullet points than long paragraphs. And utilize young people to let you know what information works best for them. This is also the age when peer counseling can be most effective because middle adolescents tend to look to their peers for information, whereas early adolescents look to adults and late adolescents tend to use other resources such as the internet. Focus on supportive adult connections, health promotion, and harm reduction, knowing that many of the behaviors that young people engage in middle adolescence are fleeting and that they will move beyond them as they are able to make better decisions. Avoid preaching to them because they spend all day being preached at. Parents preach at their teenagers, teachers preach at their teenagers, preachers preach at their teenagers. So as a healthcare provider, you want to really try and be more of a listener, an understander, and a communicator than a preacher. And finally, look for the hidden agenda and make sure you leave space for it. For example, the young person who makes an appointment for their acne comes in and sits down and spends your precious 15 minutes talking about their acne, and as you put your hand on the door to walk out, they say, "Oh, do you do pregnancy tests here?" has not done this in order to ruin your day. They did it because they weren't sure they could trust you, or maybe they just figured out if they don't ask now, they're never going to find out. And so you need to just take your hand off that doorknob and sit back down and say, "Yes, as a matter of fact, we do. Is that something you might need?" So finally, we move on to the late adolescents, young people who are moving out of school, high school, and into the world of higher education or work. Late adolescents begin to approximate adults. Their autonomy is nearly secured. Their body image and gender role definition are more settled. They are able to think beyond themselves and develop more of a worldview, and most of them have obtained abstract thinking and some useful insight. Late adolescents are more emotionally stable, and if you were to see the lability of mood that we see in early adolescence, in a late adolescent, it would definitely be diagnosable. They've developed greater intimacy skills with, again, young women having had more opportunities to develop these skills and having more skills than young men do. Their sexual orientation is nearly secured. They are much more able to express their ideas in words, and this is particularly marked with young men who really in early and middle adolescence cannot express their ideas and emotions very effectively in words. They're more concerned about the future than younger adolescents are, and they're making that transition to adult roles in school and work. In late adolescence, sexual intercourse is common, with 62.5% of adolescents by age 19 reporting having had sex, and almost 90% by age 20 to 24. The median age of sexual debut for males is almost 17 years old, and for females is almost 17 and a half. Sexual relationships in late adolescence are more stable and may have a future orientation, as well as a sense of commitment that accompanies the intimacy. This is, however, based on theories that were developed in the 60s by people who were adolescents in the 50s. And as we look into the future, we see that characteristics of middle adolescent relationships with multiple relationships, serial monogamy, and casual relationships tends to extend further into young adulthood. And in terms of brain development, it is not over. It's not over at 18 or even 21. The part of the prefrontal lobe that's linked to one's ability to inhibit impulses, weigh consequences, prioritize, and strategize is actually still developing until the mid to late 20s. In working with late adolescents, because they are more abstract thinkers, this gives you the opportunity to use more traditional approaches for health education that rely on understanding the consequences of their behaviors. Do provide the option to include close friends and or partners in office visits, remembering that you always need to spend time with the patient alone, but that they may want their partners or friends involved in terms of providing them with support during their visits. Some final words about brain development and decision making. First, most of the research on adolescent brain development has looked at structure rather than function, although the latest research is beginning to use functional MRIs to look at the areas of the brain that respond. Keep in mind, though, that we cannot necessarily say that structural changes automatically lead or are responsible for those functional differences. New findings related to function indicate that adolescents do show adult levels of intellectual capability earlier than they show evidence of adult levels of impulse control. And most importantly, context makes a difference. So a young person in an emotionally charged situation responds with a different part of their brain and makes different decisions than when they are calm and objective. Therefore, you cannot base your assumptions of their abilities to inhibit their impulses and make healthy decisions on the conversation you have in a quiet exam room. In the moment versus projecting into the future results in different decisions, and in the moment decision making is the last thing that adolescents achieve. Since as adults, we learn better when we can take what we've learned and apply it to real life situations. We're now going to walk through two cases, one of an early adolescent and one of a middle adolescent, and try and apply some of the both theoretical background and brain findings to how we might manage a clinical situation. So let's start with Carlos. Carlos is a 13-year-old boy who was brought in today by his mother for an annual exam. He doesn't have any health problems and mom doesn't have any particular concerns. He's a well early adolescent. He's developmentally pretty much on track with a sexual maturity rating of 2 and 2. This is the same as his Tanner staging. And his BMI is 28. Thinking about his elevated BMI, we do some further information gathering about his diet and activity and discover that Carlos eats a diet that's low in fruits and veggies and very high in refined sugars and processed foods. He's drinking 1 to 2 sodas daily, and he has juice with breakfast every morning. When you're talking about his dietary intake, mom adds in that she gives him juice because it's healthy. He's in PE at school, and he also goes to an after-school program which offers a variety of activities. So you can choose between homework help, table games, and organized outdoor activities. Carlos primarily plays table games. He also when we ask him about his activity in PE, he says they do a lot of standing around. This is pretty typical of middle school PE, where studies have shown that there is a maximum of 15 to 20 minutes of actual physical activity in a whole period of physical education. So let's take some of the information and strategize for an effective intervention. What I'd like you to do as we walk through the next couple of slides is consider Carlos's developmental stage and think about what the best approaches might be for addressing Carlos's weight. So let's start with Carlos's physical development. He is just starting to grow. And so what we often try to do with early adolescents is have them hold steady with their weight, not have them lose weight, because especially with boys at 13 and 14, they will grow into their weight. And it's very reassuring to both the youth and parent if they understand that they don't really have to go on a diet or lose weight. They just need to make some modifications to hold steady so that their height can catch up with their weight. Now, thinking in terms of being an early adolescent, we know that the huge preoccupation for early adolescents is what's normal. They're very concerned about being normal. And they're also very concrete thinkers. So showing Carlos a BMI chart and where he fits on it as compared to his peers will help him to get an idea of how, quote, normal he is, and will reinforce some of the conversations you have in terms of helping him modify his behavior so that he reaches his goal of, quote, being normal. Finally, remember that early adolescents are concrete thinkers and very present-oriented. So focusing on the consequences of being overweight today are going to be much more effective motivators than looking at long-term health impacts of being overweight in terms of chronic conditions. So let's translate that for Carlos. We don't want to really spend our time talking about arteriosclerosis, heart disease, hypertension, diabetes, even if based on his family history those might be things that we're concerned about. We really want to talk about being able to run hard, play well, look good, and be like the other kids. Now remember that with children and adolescents up to age 20, we're using BMI charts and percentiles rather than absolute BMI. So if you take a look at where Carlos is at age 13 and plotting out his BMI, you'll see that he's above the slope for any child his age. And so actually concretely looking at this, let Carlos find his place on the chart and ask him what he thinks it means will really drive home the message that this is not, quote, normal or like his peers or typical, but is actually significantly overweight. Now we know that small steps that are achievable are the best approach for any client who's trying to engage in behavior change. And we also know that Carlos has some very significant uh, dietary intake that's high in calories, low in nutritional value, and that if he just cut out the soda and juice, it would make an enormous difference in terms of him holding his weight steady. Now, Carlos is an early adolescent, so he's a concrete thinker. So having these kinds of visuals that make sense to him, that he can understand, and also that mom can look at, are quite impressive and effective. So you can see these visuals are showing the number of sugar cubes or spoons full of sugar that are in each of these drinks, and focus not only on the sugar content for the liquid, but also portion size. And so this can be used for both emphasizing portion size and empty calories. And then you can help Carlos to set some goals related to these, rather than just imposing on him, you got to cut out the soda. He needs to understand the rationale, but it needs to be a concrete visual image that helps him understand the rationale. Now, Carlos is 13, and most 13-year-olds don't have a whole lot of disposable income. So talking with mom is a really important part of an intervention with an early adolescent. It becomes less significant with middle adolescents and late adolescents because they find ways to get their food outside of the house. But for a 13-year-old, who buys the food and what kind of choices the food purchaser is making make a really big difference in what this young man is going to eat. So here you can see, again, a simple visual that works for both young people as well as adults that talks about how to build a healthy plate. And by talking about what's going to go on the plate in front of Carlos, we'll open the door to talking about what food is available at home. So again, here the take-home message is that engaging with parents as well as with the young person in early adolescence is a very important aspect of any intervention. Finally, we have already heard that Carlos is relatively sedentary, and we really want to encourage him to be more physically active. Now, problem solving around physical activity, especially for overweight urban youth, can be very challenging. There are lots of reasons that young people are not physically active. They may not live in a neighborhood they feel safe going out. They may not be interested in team sports, or at this age be able to qualify for team sports because they're already overweight and underconditioned. So the key here is finding out for Carlos what activity options there are in his world. As you can see from the pictures, there are certain pretty predictable activity options for a middle schooler. One might be that they can take the stairs at school, and sometimes we find that overweight kids will find ways to tag on to the elevator in order to avoid taking stairs. Second, we know he's in PE, but is he physically active in PE? So helping him to strategize how to be more physically active in PE. And finally, now that there are physically active options for gaming, if he's a gamer and if he has those options at home, encouraging him to do some of the activities that are more aerobic and will cause him to burn more calories. So now let's move on to a middle adolescent case and take a look at Joe. Joe is 16 years old, and in response to questions that you ask him about substance use, he tells you that he's been smoking and drinking some with my friends, but no big deal. I mean, I can quit anytime I want. This is something that we hear very frequently from middle adolescents. They are under-concerned about their risk, don't really perceive their behaviors as risky behaviors, and yet we as adults have many concerns about the impact of their behaviors. Based on what Joe has disclosed to you about his smoking and drinking, you do a deeper assessment and find that he's binge drinking 1 to 2 times a month for the last 6 months. He states that he came home drunk one night and that his parents had very different reactions. His dad laughed it off, kind of like one of the boys' responses, and his mom grounded him for a week. In exploring the home environment, he states that his parents are social drinkers and that he's never seen any of them drunk, which is reassuring in terms of Joe's potential for alcohol problems. He also reports that he has 2 groups of friends. what he calls my partying friends and what he calls my serious friends. As a savvy clinician working with an adolescent who has disclosed significant substance use, you decide to administer an objective evaluation of his level of substance involvement. And so you have Joe complete a craft screener. Now, in using the craft, you want to engage the young person in the process. So rather than asking them questions that you mark off boxes, give them the form to complete or have them do it on a computerized form, and then review it with them so that they see what their score is and they see in print what the meaning of that score is. On Joe's craft, you can see that he's answered yes to number 1, that he has ridden in a car or driven a car under the influence. In his case, he doesn't have his license yet, but his partying friends do, and he has ridden in the car with them. He's marked number 2, that he has used alcohol to relax. He's marked number 4, that he has forgotten important things because of his alcohol use, and in his case was related to a blackout with binge drinking. And then number 6, as we know, he has gotten in trouble. His mom grounded him for coming home drunk. So certainly with Joe, we have cause for concern. He has a craft score of 4, and there definitely needs to be an intervention here related to his substance involvement. But how do we make an effective intervention with a middle adolescent who's drinking with a bunch of other kids, and they all think it's absolutely normal? So again, I'm going to ask you to think about his developmental stage and what approaches you might use for addressing his alcohol use. So what are the key developmental considerations? Joe is a middle adolescent, and for middle adolescent, peer relationships are paramount. So exploring some more about his peer relationships and his perceptions of his partying friends and his serious friends will give you a better idea of the context of his use. What does he do with his, quote, serious friends? What kinds of relationships does he have with those other young people? What does he do with his partying friends? Who does he have fun with? Who does he spend more time with? Who would he rather be with? Who does he think are the better influences? Middle adolescents can reflect on these questions and come to some aha moments about the decisions that they're making when they're in a calm, quiet environment, like sitting with their provider in an exam room. Joe also should be able to think abstractly at this point, or be developing his ability to think abstractly. And so trying to help him think through the what-ifs of drinking and driving, which is probably the most dangerous activity he's engaging in right now, is going to be a productive line of questioning. Giving him a scenario, or better yet, asking him to give you a scenario of drinking and then driving a vehicle, and what might happen, and what might happen after that, and after that, and after that. What are the consequences, both for him, for others, and for his friends, if he's involved in drinking and driving? And change is a dynamic process, and Joe needs to be engaged in that process. So rather than prescribing for him what he should be doing, we need to really be discussing with him what he thinks he can do. Is he willing to even think about changing his binge drinking? Using something like the readiness ruler shown in this slide helps a young person to really identify where they are on the scale of readiness to change. Ask Joe to pick a point on the scale that shows how ready he is to think about changing his binge drinking. And then, regardless of what point he picks, help him to identify facilitators and barriers to that change. In other words, if Joe says, well, I'm a 4, you might then say, okay, you're a 4, which means that you're willing to consider it, but you're not quite there yet. Why are you a 4 and not a 1? This is going to help Joe to identify what are the facilitators, what are the reasons that he wants to consider changing his drinking patterns. Once you've had that discussion, then you need to also explore barriers by asking Joe, why are you a 4 and not a 6? What's keeping you from being able to be a 6? And this is going to then elucidate all of the barriers that might keep him from really engaging in change. For example, he enjoys being with his partying friends, and that's what they do together. Now, we not only need to know how willing he is to make a change, but we also need to know how confident he is that he can make a change. So this same process in terms of asking him about his confidence in change will be productive in then planning with Joe what the next steps might be for him. And finally, we know that Joe is at significant risk here. And we also know that he is a middle adolescent who part of his job description is increasing independence. However, we're concerned about Joe. We're concerned about Joe's parents' response to his behaviors, particularly Dad's response. And we need to really engage with his parents, but do it in the context of his permission. So these are recommendations from the NIAAA in terms of intervening with highest risk adolescents who are substance involved. So we've talked about the motivational interviewing using the readiness ruler. We know already that Joe's parents know, and so we need to ask Joe if we can speak with his parents about our concern. Reassure him that you're only going to share the information that he's given you permission to share. Have him present when the conversation takes place, and discuss what are appropriate supports for Joe once he's made a plan to address his binge drinking. So in closing, remember that the adolescent brain really is a work in progress, and that each stage of adolescent development brings different and unique challenges and stimulating opportunities to build your skills in working with young people.
Thank you, Erica, for your presentation, and here are some references and resources that were used in the development of this module. This concludes our online training session on adolescent brain development and application to clinical practice. Again, this webinar is part of a series of online courses provided by the California Primary Care Association as a demonstration of their mission of strengthening its members' clinics and networks through advocacy, education, and services in order to improve the health status of their communities. For more information on CPCA and its services, please visit www.cpca.org. For other online training opportunities, please visit the websites for the California Primary Care Association and CARDIA. Thank you for your participation.